Great. Welcome, everyone, to our panel today. I'm Sherry Boland. I'm a professor of medicine at Case Western Reserve University and the Metro Health System, as well as one of the PIs at Case Western Reserve University for the Heart Healthy Ohio initiative. And the purpose of our video today is really to share some of the work of our initiative for statewide spread to help other folks implement these activities. And just for those who are not familiar with our Heart Healthy Ohio initiative, this is an ARC-funded collaborative that's across the state that brings together primary care practices, payers, professional organizations, and other key stakeholders that are working together to really improve cardiovascular health across the state of Ohio. And as part of that statewide initiative, we're actively working with about 50 primary care practices across the state, specifically around hypertension control and smoking cessation. So I am delighted to have a wonderful panelist group here today from that initiative who can help showcase this effort and talk more about what we're doing. So I'll just start and have everybody introduce themselves. So Ashley, I don't know if you want to go first.
Certainly. Thank you so much for having me. My name is Ashley Sneed. I'm a family nurse practitioner at the Ohio State University Wexner Medical Center, and I see patients at our Gahanna site. And for this project, I have been the clinician site lead. So my job has been mostly to actually come up with the interventions that we have been able to implement.
Great. Well, thank you so much for joining and sharing your work today. Shalina, do you want to go next?
Hi, I'm Shalina Nair. I'm an associate professor here at Ohio State in family and community medicine, and I also see patients in the Gahanna Clinic. And for this project, I am one of the quality coaches. So for people who are doing the work in the clinics, if they have questions on QI, I can help with that.
Great. And last but not least, Randy.
Good morning, Randy Wexler, also from the Gahanna office. So I know these two. I am a professor in family medicine here, and I'm the site PI as part of this for Ohio State with regards to the initiatives that we're doing.
Great. Well, welcome to all three of you today, and thanks for being here. And I thought we would really just start with Ashley to tell us a little bit about the interventions that you're doing, what early successes and challenges you've had in implementing the work around hypertension in the office that others might emulate.
When I think about our successes, I think about them in two ways. One is just about the morale in the office and the culture. And I think what was an early success was that we had a lot of buy-in from everyone, from our front desk staff to our medical assistants to our nurses. They were all hands on deck. They were willing to give their feedback, give ideas, lend their support. We had front desk staff offering to outreach to patients who maybe have blood pressures that were not controlled. So I think that really kind of set the tone that this project was going to be successful because people were very interested in it. And then thinking about the first initiative that we actually put into place that was successful was a process by which we encouraged BP to be performed last at the end of the rooming process. Sometimes that was happening, but sometimes not. So we created a mnemonic around that called GHOST to really help emphasize how important that was. And I think that was our first major success. It was really easy to do. It didn't require any resources. It just required us to be intentional about how we were doing it.
Great. Yeah, I love the fact that you mentioned sort of teamwork, because that's so important for getting everybody on board and wanting to do it and getting at least the people that are most interested to work on it first and show how successful you can be really helpful. So how do you think data is leading your effort, Ashley, for this initiative?
So our leadership created a high value framework dashboard to be able to monitor and track a lot of different quality metrics that we are accountable for: blood pressure, diabetes, colon cancer screening, et cetera. And so we were able to kind of use baseline data from our BP metrics and then monitor those metrics over time. a huge thanks to Dr. Nair, actually. She showed me that within that dashboard that we had a way to actually break down metrics at a weekly trend. And so in the early part of this year, there was a new pilot that we were doing where we were going to have 3 different providers have their blood pressures done in the chair instead of on the exam room table. And so I was able to look at, okay, by each provider, what did their blood pressure look like in the weeks prior to the project's implementation, and how it looked on a weekly basis going forward. And I think having that was really exciting, because instead of waiting for the next months of data to kind of roll in, which, at the office level, those numbers move very, very slowly, but to be able to see it on a provider by provider basis, the impact that our intervention was having was really quite encouraging.
Great. So yeah, that sort of speaks to, we have a dashboard, a monthly dashboard using the electronic health record data around certain things like if the blood pressure is high, did somebody repeat a blood pressure, right? So those are things we're trying to work on. But that often when you're doing quality improvement efforts, we do need more data around a very specific effort. And so that's great, Shalina, that you guys were able to talk a little bit internally and support some of the data sharing that might be useful for individual efforts. Besides the GHOST or having people do the blood pressure last, Ashley, what are some other successes that have really moved the needle for you all around hypertension? Because you were one of our first co-design sites and you've had some improvements there. So I'd love to hear what other things you think were really critical. It sounds like one of them is this accurate blood pressure measurement, both in the office room, so they're not on the table, and also doing it last. Any other successes around that you think impacted the blood pressure? I know we were working a little bit on scheduled follow-up and other things.
Yeah, we have really placed a lot of emphasis on utilizing home BP measurement as well. So we have rolled out a process by which we can help to evaluate the accuracy of a patient's home blood pressure device. So they bring it into the clinic, we perform a series of different readings, and then we're able to give them feedback on whether we feel this monitor is suitable for monitoring or not. Additionally, we created a written resource guide that provides a lot of information about how to select a BP device to use at home, which ones are validated, what are some tips about being able to use that device properly. We did borrow one of the handouts from the Heart Healthy website that has a great little infographic that talks about how you should be sitting with your back supported, resting for 5 minutes, having a bare arm, having your legs uncrossed, so that when people are measuring their blood pressure at home, that they're doing it properly. So we created this written resource that has just some really quick, necessary information that patients can use around selecting a monitor, doing it properly, and then general tips about how to manage high blood pressure as well. That has been very well received by patients, to be able to have some very clear guidance about how to pick a monitor, what size cuff do you need, who might be appropriate to use a wrist cuff. So we address all of those things. And then in looking at how many devices we've actually been able to check in the last year, we've checked almost 100 now, which I think is pretty good. So I think all of those things have been pretty successful initiatives as well.
Great. No, that's fantastic. I know a lot of people are trying to work on home blood pressure monitoring and getting that set up and getting people back. So I think setting up those kinds of standard processes are great for the patients, and hopefully help standardize so more and more people are getting those. Ashley, any last comments about getting people scheduled for that follow-up where you're bringing them and doing like the home blood pressure and the education? Any lessons learned from that?
I think that has been a little bit of a challenge for us. We have had a number of provider transition and staffing issues, so our patient access just isn't at an optimal space right now. We have, though, created a more standardized process for utilizing our ancillary medical assistant schedule to be able to do some of those BP rechecks. Knowing that our patient access isn't where we want it to be, not always insisting that all BP rechecks happen on the provider schedule gives us more opportunity to still ensure that those checks are being done, but not always necessarily needing a office visit on the provider schedule to be able to do that. So that's one other resource that we've really been trying to utilize this summer.
That's great. Yeah, thinking about who might be available on the team to try and help, I think is fantastic. So I think I'm going to ask a little bit, I'm going to switch to Shalina and just ask, how has this program provided opportunities for working in collaborative teams that you've noticed? I know Ashley just gave us an example of that.
Yeah, no, it's actually been a really great opportunity to work in care teams across all levels of staffing. So including the front desk, as she mentioned, who were doing outreach, our medical assistants and our providers. So I think there was a lot of engagement in this work, and people were really happy to contribute for the good of our patients. I think more specifically, our medical assistants had a lot of engagement in the process because they were really the ones actively involved, especially in regards to the home blood pressure monitor calibration process, as well as kind of adjustment of the in-clinic processes using the automatic cuffs from a seated position. I think it adds a lot of value to their work. I think personally, I'm just going to speak, I found it really enjoyable to have Ashley leading this project and also have many of my patients be part of her early pilots in various initiatives that she was doing, especially the blood pressure cuff calibration on the nurse schedule. That has been really so valuable for my patients. And so, yeah, just really great collaboration across the clinic.
Great. And I was going to ask back to you, Ashley, not to monopolize your time, but then I'll ask Randy also. How have you been engaging around social determinants of health strategies as part of the initiative? Because that can be so important for a lot of patients and how we handle their health.
So it hasn't been a highlight for us yet, but we do have a project that we are rolling out starting tomorrow that will incorporate a little bit of social determinant screening. So I'm very excited about that. So to give a little background about that project, on the Heart Healthy website, there was a template listed for how to use nurse-led blood pressure visits. And it was an idea that I had, but I didn't have enough structure around it to actually implement it. And so when I saw this tool, I'm like, oh, that's perfect. We can just kind of modify this for our own use. And so in that template, it asks questions about patient compliance with their medications. Are they able to name their medications? How many missed doses had they had? And so it gives us an opportunity to pair the nurse with the patient and ask those important questions so that if patients are not able to name their medications, maybe there's a literacy issue, maybe they're not taking their medications because there's a cost issue. It gives us an opportunity during those visits to specifically look at reasons why patients are not able to be compliant with the things that maybe we have recommended to them. Maybe in our very, very busy office visits, we've not had enough opportunity to be able to explore those issues in more significant detail. And so it is an explicit part of the template for these nurse-led hypertension visits that social determinant of health screening is included, and kind of have some plan for follow-up based on any barriers that are identified.
Great, that's fantastic. Yeah, often it can take 6 months to just get some of those more basic things you mentioned, Ashley, in place. And I love the idea of incorporating that into the nurse visit template or MA-led visit. That's fantastic. Randy, anything you would add just from a higher level, what the Heart Healthy Ohio initiative may be doing around social determinants of health strategies that practices could use?
Sure, and I think it's important to remember when we look at disparities, particularly in hypertension, underserved populations and communities, and especially African American patients, have higher rates of high blood pressure and poorer rates of control. And so we really need to figure out ways to make sure that we're treating everybody equitably. And one of the ways to do that is to incorporate social determinants of health into what we're doing. Ashley mentioned some of those ways. But the other thing that happens is as one continues to add more to what one's doing, to broaden out on an earlier theme, it takes teamwork. You can't do it all during the time of a visit. And so on the Heart Healthy Ohio website, there are actually tools, Ashley's mentioned one of them, that are helpful in starting the process of incorporating social determinants of health, but also giving people some ideas on how to expand the team. And a lot of times we think of the team as either being the provider and the MA or the provider and the nurse. Sometimes it incorporates other people in the office, but the team is also the community. And so incorporating community resources and partnering with groups in the community dedicated to underserved populations, as well as focusing on reducing social determinants of health, can also be very helpful, because that allows a broader footprint with regards to improving cardiovascular health, but does not necessarily require financial resources to do it. It's a time investment, but that's what we're doing already, and it allows us to expand that and obtain resources that might otherwise not be thought about. And so I would encourage folks to go to the website and look at those resources kind of as a pathway, if you will, to incorporating social determinants of health, kind of in a team-based manner that allows one to expand what they're doing.
Great. Thanks so much, Randy. So I think the last thing I'll just ask all of you to help us answer is really just looking ahead for your practice and patients. What do you hope to achieve from this experience moving forward? And I'll start with you, Ashley, and then I'll go to everyone. And this is also an opportunity to share any last thoughts or comments that we didn't get a chance to touch on.
I hope moving forward that participating in this project is just a good model for how you can be curious about things and have processes that don't take a lot of money or resources to be able to make an improvement. And then throwing back to the kind of team-based model, I think this process for me really showed that, like, a job title or a role as being a doctor, a nurse, an MA does not have a monopoly on whether you can make a difference, because really the people that are making the biggest impact on this work are the people that don't really have big, fancy, illustrious titles. And so I hope that going forward that we will continue to partner with our staff and team on all levels to be able to make a difference.
Great. Thanks so much, Ashley. Shalina, any thoughts, comments?
Yeah, kind of echoing what Ashley said. I think it's just been really exciting to be part of a team-based quality improvement initiative that is focused on improving blood pressure control for our patients and also improving their cardiovascular health as well.
Great. And Randy, any last thoughts?
Yeah, in addition to, as mentioned, serving as a template for perhaps other interventions around other diseases, I think what this really does is it teaches us how to expand our delivery of care outside of our office and outside of the exam room, because patients only see us a couple times a year for a limited amount of time. And by having them connected with resources outside of the office that can help them more long-term, they can find support that they need, whether it be financial, housing, or otherwise, I think becomes really important. And we tend to forget that when we're trying to get through a 15-minute office visit. And I think this and the resources here help remind us that there is a lot more we can do for patients, but it doesn't have to be done during the time frame of an office visit.
Well, great. Well, thank you all so much for participating with us today and sharing what you're doing, and look forward to further conversations with all of you.